muscles or nerves or anything else for that. They go to someone else and they're only looking in their mouth at the teeth, and they don't start looking and they say, no, it's not dental. Well, it could be dental, but you just don't know it. It's some of the muscles of mastication. We can all provide this treatment here. So what I'm trying to do is, at least go ahead, do my basic examinations, get those out of the way, treat the muscles first, especially if I find trigger points there, and if these trigger point treatments work, then I know it's muscle. If they don't work, I know it's not muscle, and that, by the way, is a huge advancement for the patient. By the way, that's huge for the patient, because now I know that the trigger points are not what's causing this muscle. Now I've got to try to find the right referral for them, and you rely on your specialist for that as well. So it's all about working together, and certainly physical therapists, when it comes to muscles, can be very helpful here. If it's stress, if it's tension, if it's psychiatry, psychology, then you've got to make the appropriate referral, or at least, I'm a dental professional, so I'm usually not going to refer people to a psychologist or psychiatrist. I will refer them to a physician and give them a little bit of a heads up saying, listen, I did everything I can do. I don't know if you're going to find anything. I could suspect that maybe, something is going on, and some of this might be psychosomatic or something like that. So, you've got to deal with what you've got, but you're going to be amazed at how much of this is muscle and when treated properly. So let's get to these treatments, and you'll be able to see what we're going to go ahead and do for these things. Bruxism appliances is really not so much a part of this course because, like we said, we're not talking about the occlusion-based problems here. Occlusion can be a whole different course on its own. Bruxism appliances, though, we do cover quite a bit in our dental sleep medicine, and this is for dental professionals, dental sleep medicine and bruxism therapy. We treat that in that course pretty much very, very heavily, So I'll refer you over there for right now, because one thing's for sure, and I think we've established this pretty well at this point in time. It's the orofacial pain and TMJ, most of it is not at all related to the occlusion. Bruxism appliance for right now, only for the point of going ahead and protecting their teeth from these muscles that are grinding and clenching and beating the heck out of these teeth, then yes, you should protect them. But we're going to deactivate some of this, of the trigger points certainly in the muscles. That'll get them in less spasm, less clenching, and when we throw in a little bit of Botox later on, we'll talk about that for the uninitiated, then that will reduce the intensity of contraction. That will really help their bruxism quite a bit. And then we're going to go in a different direction a little bit when it gets to bruxism. But you need to know, though, and it's really crucial that you understand, some bruxism appliances can make muscle, if it's a muscle-based pain, worse. Some of them can make it better. And sometimes you just don't know until you actually put the appliance in. But, again, there's a logical process to that. Don't just make bruxism appliances for patients with orofacial pain, because many times they come back to you, you've had the experience, and they're worse, not better. And now you're really scratching your head. I don't get it. It's kind of set their jaw back. And then you've got to take something else into consideration, which I'll get into later on when I show you an unbelievable case that will really blow you away. But you'll see how many facets to all of this, to this case, and some of the cases that we all participate in all the time. So bruxism appliances is at your own discretion for right now, but it's not the treatment of what we're looking for when it comes to orofacial pain here. Now, here are the frontline treatment modalities that we are all going to go ahead and use. Anything that brings more blood flow to the area generally is thought to start the healing process. So moist, hot pack, cold pack, whatever makes, especially if it's a myalgia. And especially if it's just a muscle pain and it's a sore muscle, it's just like any muscle pain around the body. Hot packs, cold packs, whatever makes it feel better. Ultrasound, TENS units, low-level laser therapy, which again we talk about in the more advanced parts of this course, can be very significant and really help a lot of the muscles. A lot of these things help a lot after you've treated their trigger points, because it just helps the muscle heal a little faster. It just reduces the muscle pain, initially and longer term, so it can help the muscle not develop that trigger point again, because trigger points, like anything else, can come back. What I'm looking for is short-term and long-term relief. but there's never a guarantee that this is going to not come back here. And I think when it comes to orofacial pain, I think it's really important to understand that there may not be a cure for their orofacial pain. It's more about anything else in the medical world, which is, for the dentist, is a little different perspective here, because dentists, we see a hole, we want to fill it, it's cured. But when you're talking about pain, and pain therapy, no matter where on the body, but certainly when you're talking about head and neck, TMJ, or orofacial pain, it's much more along the medical model of trying to manage it. Now, if I can get short-term relief, that's great. It might come back. I'll have to treat it again. If I can get long-term relief, that's even better. But I'm never going to guarantee a patient that I'm going to eliminate their pain forever. But you're going to be amazed at the amazing things that you can do for patients when it comes to all these frontline therapies here. But these are just the adjunctive treatments and the extra treatments here. Muscle relaxants for orofacial pain, and this is not the pharmacology lesson on these medications. Learn about them. If you're comfortable, then go ahead and prescribe them. But this is not my first line of defense. Unfortunately, or fortunately, many patients already come in with a lot of these medications here. So, you know, we're going to go if I deem it necessary. If some of my trigger points injections help, or they help to a certain extent, they don't get it totally, I may go to Flexeril, although I prescribe these things. It's very rare that I actually prescribe these things, but Flexeril is known to be, it's a well-known muscle relaxant for these. Medrol dose pack, Medrol dose pack and prednisone and steroids is pretty much the catch-all. When nothing else is working, I have no idea what else to do, let's throw some steroids at it. It is unfortunately too much of a feeling that many medical and dental professionals may go ahead and use many times. Don't prescribe what you don't know. That's the bottom line for these things. What I'm going for are real physical treatments first, and then go later. Now, earlier in this course, and you've seen, some of the things, you saw that one patient demonstration about, Topamax, and some people like to use it. The neurologists typically love to use Topamax, even though it can make patients a little confused, but then they back up on the dose. Again, I just, presented at a major neurological conference there, and I was discussing medications with a number of neurologists there. Many of them use Topamax, and what they do is when they see that kind of fuzzy feeling that patient is getting, and they get thin and stupid and confused, then they cut back on it, and they say they can generally find a good level for that. But don't use Topamax unless you know what you're doing. And again, those are used for some migraine-type headaches and different kinds of headaches that are out there. So you really need to know those things. What we're going to use is really go to the source of this pain and try to get rid of a lot of the pain for the patient here. And one of the ways we're going to do that is with something called ethyl chloride. And ethyl chloride is a refrigerant that's made to go ahead and be sprayed onto skin. And it seeps through the skin, it gets into the muscle, and it's a great muscle relaxant. It's really an amazing muscle relaxant. It can be used as a topical skin anesthetic, but you have to be careful. If you spray this in one area for too long, then the patient actually can get frostbite because it is that cold on there. You have to protect the ears, the eyes, the nose, the mouth, all those different things. You don't want to put it onto broken skin at all. This is only on good, healthy skin. I use it before, sometimes in conjunction with trigger point injections. Many times, this is the treatment all by itself. And it's enough to settle the muscle down, and again, especially if a muscle is in spasm, get them to open. The most amazing thing here is, and it's Gebauer is the biggest maker of the ethyl chloride in the U.S. And again, outside the U.S., you can get Gebauer, you can get a number of different products. Even in the U.S., you can get different products, but they're the most well-known for this. I like a spray bottle, and we'll demonstrate through some videos on exactly how to use this. And we're going to follow all those chains of the muscles as we go up and around. And we're going to do a few different passes. It's amazing. Now, for the dental professionals here, I'll tell you how I first learned to use this years ago, and I saw a demonstration at a dental meeting of this, and it's really kind of amazing here. If you have a patient that has a very limited opening, and you're trying to work in the mouth on some of their teeth here, but they can't open quite a bit, generally that's going to be their masseters may be in spasm. That's really limiting their opening. Temporalis may be in spasm. Once you learn how to go ahead and use this and spray this on, you do a few passes on that masseter. It's amazing. Their jaw will pop open right in front of your face. You can go do the dental work that you go ahead and need to do. So I've used this in the dental office many times just to get access for the dentistry, because generally if they can't open very wide, what's going on? A muscle's in spasm somewhere. Generally, it's going to be a masseter temporalis, and generally they usually have some orofacial pain that we've ignored or we haven't really discussed with the patient there as well. And that's a great demonstration of, I can use it clinically for my dentistry, but I can also go ahead and use it to get rid of some orofacial pain here. And this is pretty much the spray pattern that you are going to go ahead and use. And just like when we did the examination of caudal to cranial, I'm going to go ahead and start and slowly take about 4 to 5 seconds each one of these patterns, never staying in one place for too long, but it's not a real zip, as you'll see. I'm going to slowly point this, and it's the kind of spray bottle where you've got to click it all the way open completely initially. And if you only open it a little bit, some people are a little hesitant. And you'll practice it once you get to live patients and once you get a bottle in your hands, is you open it all the way and the spray starts coming out. So you've got to be focused and aimed where you want to go, and then you go ahead and just follow up the trapezius, go up the sternocleidomastoid, go around to the splenius capitis, and go up the masseter, and then spray out the temporalis. And you'll see their hair will get a little frosty from the refrigerant that's in here for that. So that's the pattern you're going to see. And many times, the ethyl chloride is used by many physical therapists in their offices, but they also prescribe it for patients, and patients get it. And if they've got a problem with their knee or their leg in areas where they can spray it themselves, so it's not unusual for a patient to do this on themselves. Much harder for a patient to start spraying themselves up and down their head and neck and without getting stuff in their ears, eyes, nose, and throat. So that's not something that's recommended, but it is something that's recommended for you to do in the office. It can get patients a lot of initial relief. Use it before, during, after trigger point injections, or as its own treatment, because this spray pattern is its own treatment. You're staying about a foot and a half away from the actual area where the spray will contact this. Now, again, for dental professionals, this is not endo ice. You have something in your office right now that's a refrigerant that many times you will use to spray on a cotton swab, touch against the tooth. If the cotton swab gets ice cold, touch against the tooth to see if the tooth has a normal reaction to it and if the nerve of the tooth is alive or dead here. That's a tetrafluoroethane or ethanol kind of a mixture. Not for use on skin. Ethyl chloride is what you want for use on skin there. So you'll go ahead and see some treatment demonstrations in this with some of the other demonstrations that we're going to go ahead and do. So now let's go ahead and get to the trigger point injections, and we use these therapies all together here. Now, we're going to use a trigger point injection, and we're going to go ahead and use, we can use a number of different size needles, gauges, and those kinds of things. But to just give you the general idea, we are going to generally use a needle that is going to be anywhere from 22 to 25 gauge, something like that, a little bit bigger, and also 1 inch is a good starting point. I have 1 and 1.5 inch in my office. I probably have some half inches around there too. 1 inch is generally pretty good for most of it, but if you've got a deeper muscle you need to get into, it's nice to have a 1.5 inch, and these are typically Luer lock needles that are available, and then your syringes that you have. Now, there are some syringes out there, we use them a lot in our courses, which are 22 gauge, 1.5 inch needles that are called Comfortox syringes, that are the sharpest needles out there, and that's what we love about them. We also use them for the reconstitution of Botox. We also use them for trigger point injections. And again, you just need to know your depth. Obviously, I'm not going to the hub of any needle anywhere, because most of the time I don't have 1.5 inches to work with anyway. But the reason I want a sharp tip to these needles is because I'm actually going to use the end of the needle as a scalpel in trying to break up this trigger point. Because that's exactly what the end of a needle is. It is a scalpel. And I'm trying to get in there, I'll find the trigger point, it's going to have a different texture in the muscle. It's going to feel almost like fibrous, like scar tissue, and be really thick. When I feel that, I'm going to try to break it up there. Now that is the treatment, by the way. And I want to make this really clear. The treatment is breaking up the trigger point with the end of the needle, using it as a tiny little microscalpel, if you will. That's the treatment. Now, what I inject into that area is really for patient comfort or to have some kind of therapeutic effect going long term. So let's take a look at what these things are, and you'll understand all this will come together to you when you see the treatment videos here, and you'll really understand this, and then it'll really come together once you get your hands on it and treat live patients on your own. Now, be careful about treating live patients without having been instructed in how to do this, because if you start hitting the wrong kinds of anatomy, you can cause the patient some real problems for that. So get to a live patient course really soon so we can kind of mentor you one-on-one, and really you'll get the experience that you need without doing any damage. That's what we want. So, you know, it's hard to learn this just from a video here, but this will, and this way you'll be able to review it as part of this course, especially when you come back from that live patient part of the course. It'll be really good for you to really understand and review it again before you go ahead and actually do it here. But this will give you a good sense of what this is. In the past, some of the things that used to be injected when I started doing this, you know, nearly 40 years ago, was some alcohol. Now, thankfully, I never used the alcohol, but some alcohol in there, because the thought was you're going to burn out this trigger point. Well, that didn't work very well, other than destroying a lot of muscle tissue around the trigger point. And much more than we are trying to do. But the whole point of trigger points, let me get to this and make this point stronger, because I touched on this a little bit before, is I want to go in there and break up that trigger point, then the body's natural inflammatory response comes in and heals that trigger point. Now, if it heals it completely, it goes away. If it heals it only halfway, and because I'm doing this as kind of a blind surgery, so if I only get half of this trigger point, then, you know, then I got to go back in later and get it, and they'll get some relief, but they may not get total relief. Injecting alcohol, the thought was, I'm going to burn out all this muscle tissue. Unfortunately, you couldn't control that, and you ended up burning out a lot more muscle tissue and ended up doing a lot more damage, and there were necrosis issues that happened from it. So we haven't used any kind of alcohol for a long time. Sterile saline, the thought was, well, let me just inject some kind of a liquid there. But again, that doesn't really add anything to what you're trying to accomplish. It doesn't add anything to the comfort of the patient. It doesn't add anything to the trigger point injection. There's no real good reason to go ahead and use it. Dry needling, again, the injection is the treatment, and physical therapists typically will do dry needling. This is different than acupuncture, which is trying to block a nerve pathway generally, and I don't know that much about it, but dry needling is that same breakup of the trigger point and not injecting anything, primarily because physical therapists can't legally inject any pharmaceuticals into a muscle or into the human body, and that's why they use dry needling. And guess what? They'll get some relief on it. But what I can do as a healthcare professional that can use pharmaceuticals, and what most of you can do, is I can use either lidocaine 1% with no epinephrine. The reason I prefer no epinephrine, if you use epinephrine, it's not the end of the world, but epinephrine is somewhat myotoxic, so I do prefer lidocaine 1 or 2%, but you know, it's really whatever you like to use, but lidocaine 1 or 2% with no epinephrine because of the myotoxicity of the epinephrine here. But, and that, what does that do for me, the lidocaine? It really just gets the area numb a little bit, makes it just a little bit better as I'm trying to find the trigger point. Now, I want to find that trigger point. I don't want to get them too numb, because if I go in there and I touch a trigger point, they will feel a sharp pain. And then once I feel that, when they feel that, I'll give them a little bit of lidocaine. I know where I'm at, make it a little more comfortable, and then I'll really go to work on this, as you will see. Now, lidocaine is only going to last a few hours, but their relief may last a lot more. Why? Lidocaine's gone. It's only to help them through that initial procedure for that treatment there. So the lidocaine is somewhat helpful there. Now, what I really want to use is some kind of botulinum toxin, which would be Botox, Xeomin. There's a third one called Dysport, but we'll stick with these two because the way you dose these things are pretty much all the same. So what I say about one will refer exactly to the other in terms of dosaging there. So what does Botox do? And we'll give you a little bit of a primer for those of you who don't know, or a refresher for those of you who do know, as to what the mechanism of action for Botox will be. But let me just say this. Botox will help that muscle for a period of 3 months, just by, as I mentioned before, reducing the intensity of contraction. So if I've gone ahead and I've done a trigger point injection and I've broken up this trigger point, now I add some Botox, that muscle can be a lot calmer for a 3-month period of time, and hopefully it doesn't redevelop that trigger point. It allows the area to heal nicely, and the muscle just prevents the muscle from getting stressed out and just relaxes it for a long period of time. I never want to put enough Botox into a muscle that puts it to sleep, because all the muscles that I'm dealing with should not be put to sleep. These are the kinds of muscles that I need to maintain their muscle competence so they can move and chew and talk and do the different things that they need to go ahead and do. But on this slide also, I want you to see, these are the 4 rules of injections, no matter where you give them on or in the human body or in and out of the mouth. These are the same 4 rules. You need to know the anatomy of the area, which we've dealt with quite a bit in this course. You need to use the sterile technique because we don't want to cause infections. You got to clean the skin off very well before you're going to inject again. I don't want to push through some kind of contaminant that's on the skin deep into the muscle tissue. So all the areas we're going to use are going to be very clean and wiped off ahead of time. Always aspirate, even though the syringes we're going to use are not the same kind of syringes I use in the mouth. Those are aspirating syringes made for that, and every dentist knows what I'm talking about. Unfortunately, out of the mouth, and the typical syringes are not necessarily aspirating type syringes, but if you do pull back on the plunger a little bit and you see some red or pink, sometimes just the fluid dynamics will pull it back a little bit, then you just take your needle and you reposition it so you're not right there, aspirate again, make sure you're clear, and then go ahead and do whatever you want. You never want to bury the needle to the hub, primarily because if the patient moves or jerks or something happens and just, God forbid this snaps off right at the hub, you're going to have to go digging to go ahead and remove it. Now, let's face it, a 22-gauge needle or a 25-gauge needle even, 1 inch, 1.5 inch, is a little hard to go ahead and have a problem with, because those are usually pretty thick. I mean, it would have to be drastic to break it off, but you never know what can happen. So be a safe injector and be a smart injector here.